முன்னாடி டாக்டர்ஸ் நிறைய வருவாங்களா? முன்னாடியில் நிறைய வருவாங்களா? வரமாட்டாங்க. இல்லை, கூட்டத்தில் முன்னாடி பேர் வச்சோம். வேண்டாம். சரி, லாஸ்ட் 2 ரூபா மட்டும் முன்னாடி வாங்க. அவங்க தான் நிறைய கேள்வி கேட்பாங்க. நம்ம பசங்க தான். இல்லை, தெரிஞ்ச டாபிக் தானே. இல்லை, இந்த 2 ரூபா விட்டுருங்க. முரளி
சார், குட் ஈவினிங் சார்.
குட் ஈவினிங். இங்கே நம்ம அலைட் ஸ்டூடெண்ட்ஸ் வந்திருக்காங்களா?
வந்துட்டாங்க சார்.
ஏன்னா 30 பேர் வந்திருப்பாங்க.
ஆமாங்க சார். பிசியோதெரபிஸ்டும் வந்திருக்காங்க சார்.
ஆன்லைன்ல எத்தனை பேர் ஜாயின் பண்ணிருக்காங்க?
ஆன்லைன்ல 18 பேர் இருக்காங்க சார் இப்போதைக்கு.
இங்க டாக்டர்ஸ் வந்திருக்காங்களா
சார்? நான் ஆன்லைன்ல ஜாயின் பண்ணியிருக்கேன் சார். ஜனனி கேட்டு சொல்றேங்க சார். ஜனனி ஆடிட்டோரியம் எத்தனை ஸ்டூடெண்ட்ஸ் வந்திருக்காங்க? ஸ்டூடெண்ட்
சார் வந்திருக்காங்க சார். ஆஃப்டர் டாக்டர்ஸ் 3 பேர் வந்திருக்காங்க சார்.
சரிம்மா.
அப்புறம் கேமரா மூர்த்தி சார் வந்திருக்காரு சார்.
ஸ்டார்ட் பண்ணிடலாமா?
நம்ம ஸ்டார்ட் பண்ணலாங்க சார்.
ஏன்னா மோகன் வேற வந்து உட்காந்துட்டாரு.
எஸ் சார், ப்ளீஸ் சார்.
இப்ப நான் பேசுறது மோகன் கேக்குமா?
கேக்குதுங்க சார், நல்லா கேக்குதுங்க சார்.
ஓகே ஓகே. So good evening all the consultants from Sri Ramakrishna Hospital, doctors, postgraduates, students, and also consultants and doctors from outside Ramakrishna Hospital who have joined online. And this is one of the series of meetings we have initiated 2.5 years ago during the COVID period, and we have converted now into a hybrid variety. And on behalf of the management, I thank all the participants from online and offline for joining this meeting. And today's discussions are to be done by our eminent ortho surgeons, Dr. S. Mohan, FRCS, MCH, and orthoplasty fellow. He is the consultant orthopedic surgeon, Ramakrishna Hospital. He is going to talk about the pediatrics, orthopedics in pediatrics. And Dr. R. Vijayaraj, MS, FRCS, and MCH ortho. And he is consultant orthopedic surgeon in Ramakrishna Hospital. He is going to talk about sports injuries and management. Sports injuries management. And today we are going to have 3 lectures, and the final one by Dr. R. Gogalakrishnan, D. Ortho, MCH ortho, consultant orthopedic surgeon, Sri Ramakrishna Hospital. He is going to talk about the stem cell therapy in orthopedics case scenarios. And I think today's deliberations will be useful and interesting for all the types of audiences. And I thank the speakers for accepting our invitation and coming here for delivering their lectures. Now I would like to call upon Dr. S. Mohan to take over the stage. Thank you, Dr. Mohan.
Okay, thank you very much, sir, for the introduction. Good evening, everyone. So 15 minutes, pediatric orthopedics, it's very difficult. So I'm going to go fast. Fasten your seatbelt. No questions in between. Okay, good. So, can everyone hear me in the video? So I had my pediatric training in orthopedics in this Aldeha Hospital. That's Royal Liverpool Children's Hospital. So today, briefly, I'm going to touch all the topics, basic topics in pediatric orthopedics. So I need to be in 15 minutes. So first is the clubfoot. Is the most common congenital deformities in children. So 1 to 2 per 1,000 live births. So these are the 4 deformities: cavus, adductus, varus, and equinus. So antenatal nodus, the 20-week scan that will tell us that whether patient has got this clubfoot or not. So if they got clubfoot, they can be referred to us so that we can give an antenatal counseling. That's very important, because otherwise they'll be worried that, okay, we have some problem, deformity. So antenatal counseling is nowadays, it's happening regularly for any congenital deformity child. So for clubfoot, those days they were all surgeries, but Ponseti professor is no more from Iowa. He did the Ponseti method of management of clubfoot. So this involves serial plastering. So gradually we are correcting the deformities. The treatment starts from day 1. We teach the grandmother to do the gentle manipulation. After 2 weeks, when the baby is around 3 kgs, we start the serial plastering. So this is like 5 weeks. Weekly serial casting, change every week. So we're gradually correcting the deformities, like cave. First is say cavus, then adductus, varus, and last is the equinus. So by the end of the 5 weeks, we have corrected all the first 3 deformities. So we check for the tendon Achilles tightness. If there's tightness, we do the percutaneous tenotomy. 90% of the patients need tenotomy according to the worldwide. But in India, in our hospital, I'm doing only for 30%. So tenotomy, then 3 weeks of plaster. So the treatment starts at the first month of when the baby is first 1 month old, and it finishes by 3 months, 2 months of treatment. The complete correction has been done. But the problem is the relapse. So we need to maintain the corrected foot. So we use this Dennis Brown splint. So this is the first baby in my hospital, born on 9th December 2013 here in our hospital. So this is in between of correction, like 3rd week. This is around 5 weeks. Then tenotomy done, Dennis Brown boots. So this is the final result. So this is only purely manipulation and splint. So this is clubfoot. Next common is the developmental dysplasia of hip. Those days it was called as congenital dislocation of hip. They have changed this name. So this is 1.54 per 1,000 live births. So the risk factors, that's very important in DDH. These 5 factors: firstborn, female child, breech position, positive family history, and oligohydramnios. These are the risk factors for the DDH. Sometimes it comes with the packaging disorders like torticollis and metatarsus adductus. So DDH signs, we do this to Barlow's and Ortolani test in newborns. Later on, we do this Galeazzi test. So if you see, the creases will be lost, leg length discrepancy. Ultrasound is the gold standard for diagnosing. So we use the graph classification. So I'm not going to detail. So graph classification, this is the adult child, walking child, they walk with toe walking, Trendelenburg gait. So initially, later on in the child, we do this hip arthrogram to just put a dye inside the joint and see. In this picture, you can see the pooling of dye on the medial side. That means the head is out. And we draw some lines, Parkinson, Hilgen-Renus line, and if you see the hip on the right side is outside and the upper and outer quadrant. That means it's dislocated. So how do we manage? Initially, 1 to 6 months. If you see any patient DDH, we give this Pavlik harness. But they have been talking about double nappies. That's also initially okay. But Pavlik harness, we apply this, check every week, ultrasound. First, second, 3rd week. If it's in, hip is inside, then we'll carry on with this Pavlik harness for 6 weeks. If it is out, we'll leave it, then go for the next stage. Next stage is like hip arthrogram, post reduction, hip spica. So we put the hip spica, check under the image. 4 weeks later, we change it again. So totally of 10 weeks of hip spica. Post reduction, we try until the age of 1 year. After that, if its hip is out or delayed presentation, we go for open reduction. About 2 years, 3 years, then we go for pelvic or femoral osteotomies. This is an 8-year-old. He was diagnosed when he was born, but he came late. So this is the hip on your left side is DDH. So we did the complete surgery. He needed all osteotomies. This is the hip spica. So post-op CT. So the hip joint is inside. This is 6 weeks follow-up. So we have kept the graft, acetabular is formed, the head is inside. So he is around 14 years now. He is doing well. So next is common topic is a limping child. It's very common in children. Any child crying is not putting any weight. They come and say parents are very worried. So we divide into 3 categories: toddlers, children, and adolescents. So the common first thing is transient synovitis. It's more common in the initial age group. So the child will have some viral fever 2 to 3 weeks before this presentation. So that is most common. So they limp, hip pain, limited range of movement. So this diagnosis only of exclusion. So other diagnoses are there which will come later. So this is nothing to worry. It's a transient phenomenon. Patient will settle down with rest, ice, and some anti-inflammatories. Sometimes we give traction to keep the child in bed, but otherwise this will normally settle down. So this we know normal ultrasound shows increased hip fluid effusion, blood test, everything we do to rule out any other causes of the transient synovitis. Most of this will be normal. So the other differential diagnosis is septic arthritis. So septic arthritis presents with severe pain, temperature. So this is a pathophysiology. Either there could be blood-borne or coming from near bone infection, osteomyelitis. These are the 2 ways commonly they get septic. Septic arthritis is infection in the joint. Osteomyelitis is infection in the bone. So either blood spread or from the adjacent bone, they get septic arthritis. So differential diagnosis is quite a big list. So the child will be unwell, erythema, swelling, blood test will be shown. So normally for the septic arthritis, we use one of the criteria called Cocos criteria. That's very important. These 4 factors. If one predictor is positive, 3% risk of septic arthritis. If 2 factors, 40%. 3 factors, 93%. 4 factors, 99%. They'll have septic arthritis. So the treatment is we do aspiration, washout. Any septic arthritis need to be, the joint should be washed out immediately or as soon as possible. If you leave it, it will erode the joints and they have fibrosis. Later on in future, they'll have severe problems. So septic arthritis is an emergency in orthopedics. If we diagnose or if in doubt also, we take them to theatre, do an incision and drainage. So joint arthrotomy is an emergency procedure. If the osteomyelitis is in the bone, we do drilling, appropriate antibiotics after taking cultures. So earlier the treatment, prognosis is good. The complications, if you don't treat at time, they'll have lots of complications. Especially we need to talk about the arthropfibrosis, that the joint gets fused. Next common thing is in-toeing. Most common parental concern, mostly self-limiting. Even now, if you see, many of them are walking like in-toeing. So in-toeing, first, these are the 3 important problems in child when walking with in-toeing. One is femoral anteversion, tibial torsion, and metatarsus adductus. So we want to rule out this. Most of the time, it's nothing will be there. So it's like their nature, how they walk. Just they need only training to walk properly. If you don't find any of this, just proper training and physiotherapy will do. So many of them settle down as they grow up. So in toeing, there are various other reasons which we need to rule out. Like these are the few conditions which we need to make sure. We need to examine, do an MRI scan, everything to rule out these conditions for in-toeing. So this is where normally they just sit like W position if they have femoral anteversion. Second picture is the tibial torsion and third is metatarsus adductus. Somebody need to unmute it. Okay. So treatment, as long as we find anything, we'll just observe. Children, normally we don't interfere till they become at least 8 years and beyond that. So next common is the flat foot. So if you see, normally we have an arch. Flat foot is the decrease in the arch on the medial side. So it can be 3 different age groups: infant, young child, adolescent. Infants, it's a simple positional deformity or either congenital deformities associated with congenital deformities. Young child, flexible flat foot in young child, and adolescents, tight tendo-Achilles or dorsal coalition. So each time in the clinical examination is important. Only older children we go for X-rays or CT scan to rule out the dorsal coalition. If tight tendo-Achilles, then just physiotherapy is enough. Tarsal coalition, we interfere in later age group. So flexible flat foot is when they stand, they'll have flat foot, but when they stand on tiptoes, the arch reforms. So that means there is no any bony problems. That's flexible flat foot, common between 18 months to 6 years. No pain, just the mother will be observed. They'll come, they'll ask for any boots, shoes, but I don't think nothing is going to work. Just as the child goes, most of the flat foot flexible is genetic. So if you have 10 people have 4 or 5 get better, 3 4 still have flat foot, and only 1 or 2 will have symptoms later on in their life. So flexible flat foot, nothing to worry. Shoes, no use. So this is the website. When they stand, you can see the flat foot on tiptoeing, the arch is formed. This is flexible flat foot. This is later on, tarsal coalition. This is the bony coalition between 2 tarsal bones. So this is between 8 years and adolescence. So these patients, we do a CT scan, and if they're really symptomatic, we need to interfere. So later on, flat foot, we need to think of this condition. As long as we are ruled out any flexible flat foot, everything, then look for the tarsal coalition in the age group of 8 and adolescents. X-rays, tarsal coalition, the coalition between the calcaneum and the talus. If you see the CT scan, so normally they'll have inversion aversion. This movement will be restricted. Flat foot, but that's a clinical examination. If you do inversion aversion, restricted, think of this condition. Tarsal coalition, if any symptomatic, we need to go and clear that and put some soft tissue in between. So the next is the genu valgum. Valgum is knee joint towards the midline, varus is away from midline. So many of them come with like mostly young girls, like we see genu valgum. So normal genu valgum is midline, knee joint away from midline, valgum is towards midline. So valgus alignment, if you see a normal small child, normal in child between 2 and 8 years, it's normal. So as long as we examine, ruled out other causes, then we can wait. So we just give confidence to the patients, parents. This curve is very, very important. Whatever you know, this is a Selenius graph. So if you think the first child born 0 days, they'll have varus of like more than 15 degrees. So this is the first varus, 15 degrees at birth. Then as like 18 months, the valgus becomes neutral. So if you see the graph, at the age of 18 months, they become neutral. At the age of 3 to 4 years, they become maximum of valgus, more than 10 degrees. And gradually, up to the age of 7, they attain the normal adult valgus. So if you just keep this in mind, so 15 degrees birth varus, 18 months neutral, severe valgus 12 degrees, at 3 to 4 years, 7 years, then it's normal valgus around 5 to 7 degrees. So this is very important. This is the normal curve. Sometimes they go slightly beyond, which we call physiological. That means they'll get better. So what can we do? We'll just observe them. We need to rule out other causes of genu valgum varus, which I'll come later. So examination is important. So we see the intermalleolar distance, the genu valgum varus, other causes. So we do X-rays to rule out other causes. Other causes, main cause is the rickets. So rickets, vitamin D. Most of pediatricians nowadays, they give vitamin D syrup for premature everything. But if you see a child between that 18 months is more varus, think of rickets. After 3 to 4 years, still in valgus, think of rickets. That is the first differential diagnosis of physiological genu valgum or varus. So other causes are there, but rickets is the most important thing. So between 1 to 1.5 years, the child will become more varus. Or after 3 to 4 years, they'll become more valgus. So these are the two symptoms, clinical symptoms, which you need to note under clinical signs to make sure they have this problem. So genu valgum correction. So normally we say we wait up to 10 years as long as there is no other bony problems. 10 years, if the 10 years the intermalleolar distance is more than 10 centimeters, then we interfere. Otherwise, we don't interfere. We'll wait till they finish the growth. So we have lots of charts showing how much growth left, everything. So nowadays we have this latest technique. Those days they did hemiphysiodesis. Any deformity, valgus, varus, they damage the growth plate so that they don't grow which side we want, they damage it. But recently we have these 8 plates. This is growth modulation. That is, we can put this 8 plate temporarily according to the calculation of how much growth left. So normally knee joint, 80% knees from around the knee joint in the leg. So we just try to stop. If there's any valgus, try to stop the growth plate on the medial side. Varus, try to put a plate on the other side. So temporarily we stop it. Once we get the correction, we'll take them, take the plate off. Again, they'll grow. So this is mainly this 8 plate growth modulation. Venovarum also, as I said, less than 2 years, common physiological, pathological, physiological, differential diagnosis. We always make sure metabolic bone disease. So X-rays and vitamin D, we need to consider that. Blount's disease is one of the diseases where the medial epiphysis is damaged. So we have 2 types, infantile and adolescents. So unilateral, think of this Blount's disease. Bilateral, mostly rickets or physiological. Unilateral, always think of Blount's disease. So X-ray shows the metaphyseal beaking on the inner side. So initially brace and later on osteotomies. Next common is SUFI. Any adolescent age group, they present with knee pain, always examine the hip. Because we did many of them, GPs, what they say, any knee pain, they do a knee X-ray, say fine, go home. Later on, they come with the SUFI, that slip capital femoral epiphysis. Any age group between 8 to adolescents coming with knee pain, always examine the hip. The external rotation will be limited. If you have any doubt, X-rays. So it's more common in obesity, bilateral 20 to 40 factors. Other endocrine factors are there. So there is 2 types, stable and unstable. Stable, they'll be able to weight bear, no need to do anything. Unstable, we need to fix it. Just fix in situ or later on osteotomy. This is the adult, little bit later age group. So exclusively lower the SUFI, mostly common in hip joint. So we do 2 different X-rays to see if there are X-ray findings. So normally bed rest, traction, analgesia, fix in situ. If the grading is slip, early slip, fix in situ. If it's later on, then we do osteotomies. Next differential diagnosis, Perthes disease. That is affection of blood circulation to the head. Like avascular necrosis in adult, we call this Perthes in children. So any child limping at the age of 8, think of Perthes, do an X-ray. So X-ray shows the collapse of the head. The treatment is nothing, just contain the hip. Keep the head inside the acetabulum. So most of them, they settle down. Later on, if they need anything, then go for any surgeries. Okay, thank you very much.
Thank you, Dr. Mohan. Now
Thank you.
I would call upon Dr. R. Vijayaraj for his lecture. Questions, we'll have it at the end of the session.
Good evening, everyone. I'm going to briefly talk about management of the sports injuries. I'm Dr. R. Vijayaraj, orthopedic consultant from Sri Ramakrishna Hospital. We can injure any part of the body with sports, but the most commonly injured parts are shoulder and neck. Shoulder is the most mobile joint in the body that can rotate front and back nearly 360 degrees. So that's the reason the ball of the shoulder is bigger and the cup is smaller. so that we can have. So there comes the problem. So we have so many ligaments, muscles, bones and cartilage around it that can get injured. Lot of people after the sports injuries comes with stiff shoulder, painful shoulder. Not all the painful stiff shoulders are periarthritis. The shoulder has a ball and socket joint, the head of the humerus and the glenoid, surrounded by ligaments and the bones and the rotator cuff muscles. So we can injure any part of this with sports. So the commonest problem will be pain. So what causes the pain? The injury itself and the inflammation following the injury. If there is an inflammation in the tendon, we call it as tendinitis. If it is in the bursa, it is called bursitis. Or the bones can pinch over the tendon, bursa and muscle that can cause pain. That's called impingement. What else can happen? We may dislocate the joint, either front or back. If we don't take adequate rest or recover it fully, it can keep on dislocating. That's called instability. Or sometimes the tissues around the shoulder become too tight and it won't move. That's called frozen shoulder. And it can lead on to arthritis as well in later stage. And what about the muscles? If we tear the muscles around the shoulder, the rotator cuff muscles, we can't lift the shoulder. That's called rotator cuff tear. So what age group? Younger the patient, more chances of having instability. Either they may dislocate in front, or if they have any neurological problem, they may dislocate on the back. When the age advances, there are more chances of having inflammation around the tendons, ligaments, and the bone pinching over the other bones, and we may get stiff, painful shoulder called frozen shoulder. If you are diabetic, there is even more increased chance of having a stiff shoulder. Even older group with smaller injuries, even a fall during jogging, even lifting dumbbells or any gym activity can tear our muscle. Frozen shoulder, leading to cuff tear along with frozen shoulder, and they will not be able to lift the arm. And if the injury is severe, if it involves the cartilage, you may get arthritis. And what can we do? We can identify whether the bone is involved, is it the cartilage, muscle or tendon, by doing some tests. The simple test is X-ray that can show whether there is a fracture, whether we have dislocation or arthritis. But if you want to look at the muscles, tendons and ligaments, we need a little bit more sophisticated investigations like ultrasound scan or MRI scan. But clinical examination is the key. So what treatment options we have? To start off, the doctors can prescribe painkiller tablets to relieve the pain, injections, creams, and if it is not settling, we can do physiotherapy, rehabilitation, to improve the function of the muscle, to stabilize the muscle and also to increase the power of the muscle. In later stages, if the inflammation is not settling with tablets, physiotherapy, we can give injections into the joint. Like for frozen shoulder, we can give steroid injection into the joint to reduce the inflammation. If there is arthritis or small cartilage injury, or even in small rotator cuff tears, we can give PRP injection. That is a platelet-rich plasma injection, where we take the blood of the patient, filter it, and inject their own platelets into the joint so that the tendons and muscles can heal itself. But it's during only the early stages. But if the injury is severe, like broken bones, torn muscles, or torn ligaments, then they need surgery. Either we can do open surgery or a keyhole surgery. That's arthroscopic surgery. Who will benefit from injections? if there is impingement, or if there is only inflammation of the tendons, or if the people are not be able to undergo surgery due to many reasons, then the injection will be helpful, or during the frozen shoulder stages. So, arthroscopy. What is shoulder arthroscopy? It's a keyhole surgery looking into the shoulder joint, and we can diagnose the problem, and at the same time we can treat the problem as well. In this picture you can see they have difficulty in lifting the shoulder above the level of the arm. So day-to-day activities below the level of shoulder will be able to do, but if you want to reach above the shoulder to lift something, it will be painful because of the pinching of the bone over the tendon. So what we can do, with keyhole surgery we can trim the sharp bent bit of the bone so that we can create more space so the shoulder can move freely. Calcific tendinitis. Because of repeated injuries over the shoulder, there is inflammation in the tendon and the calcium gets deposited over this tendon, causing a bony block, pinching. You can see it in simple X-ray itself. That can be removed during arthroscopic surgery safely without having any damage to the muscles. The cuff tears. We have 3-4 muscles around the shoulder joints that help to lift the shoulder, turn the shoulder, and to do with everyday function. If there is a tear in the muscle, we will not be able to lift the shoulder. And even if you try to lift, you will not have enough strength to lift the shoulder. So what can we do? We can repair the tear with anchors and stitches. The stitches will be put into the muscle and it will be pulled and fixed to the bone with a strong anchor so that the cuff can heal. Frozen shoulder. What is frozen shoulder? Like the name suggests, it's the ice form of the shoulder that is hard and stiff. So we can't turn and it will be painful. Even taking bath, brushing our teeth, even dressing ourselves will be difficult. So in the early stages, we can give injection to resolve the tight shoulder. In later the stages, we need surgery to release the tight shoulder. It's called capsular release. Or we can also do manipulation under anesthesia. That means without pain, patient can have under sedation, releasing the shoulder, and they can go home on the same day with good return to the function. Instability. As we discussed, the ball of the shoulder can dislocate in front, the anterior dislocation in this picture, or it can dislocate in the back, the posterior dislocation. So what happens? The sling around the shoulder, the labrum, tears. So every time you lift your shoulder, it may dislocate, it may come in front, or it can go in the back side also. So what can we do? If the tear is not repairable, and if it keep on happening again and again, we can repair it, either with open surgery or with a keyhole surgery. We can put stitches around the torn labrum and fix it back to the place where it belongs to make the sling tighter, to make the shoulder stable. What if we don't repair it? The shoulder will keep on dislocating, or you may have more injury than breaking the bone along with the dislocation, and it will make the shoulder unstable. So we might have played lemon on the spoon game. So where the lemon is bigger, the spoon is smaller. So when you walk, the lemon may fall down. So what we can do? We can make the spoon bigger. So make the spatula instead of the spoon. So God has given few bones around the shoulder. So we can make the area bigger by taking one bone and fixing over the small spoon to making it as a spatula. So the shoulder will stay inside. This is called bony stabilization. We can do either for front dislocation and also for the back dislocation. It will keep on happening. Even if we don't do that, What will happen? They may end up having arthritis. There is another small joint next to the shoulder, on top of the shoulder. That's called acromioclavicular joint, where the collar bone links to the shoulder. That may also dislocate. That may pop up. When you're wearing a shirt, you can see it is bumping over the top of the shirt. So that can be fixed with putting some sutures called tightrope with the collar bone with the shoulder bone, so that it can remain in the straight line. Fractures. So sports can injure the ligaments, muscles, and also the bones and cartilage. You can break any bone around the shoulder joint. If the break is simple, we can treat it without surgery. But if the break is complex, and if the person wants to go back to playing sports or routine function quicker, we can operate with either plate, screws, or nails. The aim is to make the bone to heal in a proper alignment and to return to the function early and to give better pain relief. What if we don't operate? They may develop arthritis. The broken bones may be inside the joint that may not be able to fix with plate and screws alone. If the joint itself is damaged, then we have to replace the joint, either half of the joint or all of the joint. It's called joint replacement. Earlier, the better. If you leave it longer, then you may end up having arthritis in the shoulder. Then you will end up having more chances of having a stiff, painful shoulder that would need bigger surgical intervention like a joint replacement. Similar to the shoulder, knee also have a lot of ligaments. But knee is not a ball and socket joint, it's a hinge. It's a complex hinge joint. So a lot of flexion and extension, bending and straightening. The knee has ligaments, bones, cartilage, and muscles. You can damage any of that. There may be different names for the ligament, but all the ligaments does one predominant job, making the knee stable, so that you won't fall down. You will be able to believe on your knee and be able to climb up and down the stairs. You can turn and twist easily without falling over. There has to be shock absorber when you are jumping. They are called cushions, like meniscus. And to move the knee, you need power to the muscles and bones. The front one is quadriceps with the patella, and the back one is hamstrings. And along with the thigh bone, the femur, and the leg bone, the tibia, and the patella, the kneecap, it makes us able to get up from sitting position to walk, run, jump, climb, jog, everything. Any sports injuries can damage the knee. So somebody pulling on your knee, you may end up having dislocation also. You can damage nerves, blood vessels, muscles, bone, cartilage. Even without contact sports, without even anyone pulling on your knee, you yourself can fall down. Even putting leg in the pothole or slipping a step while walking down or up in the stairs. You may twist your knee. So there is no support. You have to only believe on your cruciate collateral ligaments. So you can easily tear the ligament. The commonest ligament to tear is an anterior cruciate ligament. They call it as ACL. And if there is one anterior, there has to be one posterior also. That's called posterior cruciate ligament. That both provide stability to front and back motion. Then we have two on the side. That's called collateral ligament. It stops us swaying on either side of the knee. Then we have cushion in between. They are the meniscus. They can also tear. Then the patella. You may dislocate the patella. You can see in this picture the kneecap comes out of the socket and it can be outside. If you don't treat it properly, then all the ligaments won't recover fully. So whenever you try to bend the knee or whenever you try to walk up and down the stairs, the kneecap can dislocate. Then the cartilage. The cartilage is the smooth, glistening surface over the bone. So that is the lower end of the thigh, upper end of the leg, and the back of the kneecap. So that makes it smooth to glide, so that we won't have any friction in the knee. Some people may start to feel click sounds in the knee joint when the two bones are rubbing over each other. The cartilage wears off, starting to have arthritis. With sports injuries also, you may damage the cartilage, either in a small part or in the bigger part. Or the injury may be severe and you can break the bone also, as in this image. So how can we treat? Similar. Initial treatment is always pain relief, splinting, that is supporting the leg, so that further damage can be avoided, and we can give injections to relieve the pain, or we can give injections to heal the cartilage, the PRP injection we talked about. Then physio is mandatory to rehabilitate the ligaments, to improve the power of the muscles, and to boost our confidence. Then the surgery. It can be keyhole surgery or open surgery. Keyhole surgery, that's arthroscopy. So what is it? We can look inside the joint and at the same time look in a big computer monitor, like playing video game. We can see it in a big zoomed up way. We can see every bit of the joint, any ligament, cartilage, cushions, meniscus we can see. And if it is torn, we can repair it with stitches. If it needs replacing, we can take another cartilage from another part of the knee joint and we can fix it there. And this picture shows reconstruction of one of the ligament, the anterior cruciate ligament. We will get tendons from hamstring muscle or patellar tendon and fix it to repair the cruciate ligament. Then regeneration therapies. When you damage the cartilage, it may not grow back on its own. The medications may not be enough. So we may need some type of intervention, either a form of injection or either a form of Oates therapy. We take cartilage from other part of the bone and inject it or insert it in the broken part to help it to regrow for cartilage regeneration. So the concept is the same. Fractures. Any bone in the knee can be broken. The lower end of femur, upper end of the tibia, or the patellar, the cartilage, that can be treated with either non-surgical methods or with surgery, like with plate, nails, screws. But the aim is to improve the function and to get back to the sports or routine life faster. Thank you.
Dr. Vijayaraj. Now I would like to call upon Dr. Gokulakrishnan for his lecture. Dr. Gokulakrishnan, please.
Good evening, everyone. I thank our management, Dean sir, and PR team for arranging this meeting. I'm sorry, I won't take much time. I know most of you are sleeping, and this topic is an important topic since these days the regenerative medicine is more asked for. Many patients come to our OPD asking for a regenerative therapy, where they don't want surgical intervention as the first method. So in that, the stem cell therapy plays a major role. I'm just giving a hint of what the procedures we do in our department, and we have given a good results so far in the last 5 years. So I'd like to introduce about the stem cell basics and where and all we use the stem cell therapy, like in bone healing and treatment of non-union and avascular necrosis of the adults and cartilage injuries due to sports and arthritis and tendon injuries and enthesopathies and also ligament and meniscal injury as well. We also do the stem cell therapy in intervertebral disc degenerative pathologies. And this is a basics about the stem cell. It provides new cells for the body as it grows and replaces that specialized area with its own cell, so which has already been damaged. So they can divide and replace that structure with the native cells. And these are the different types of stem cells, which is embryonic stem cells, which we take from the cord blood, which can be pluripotent cell. And there are adult stem cells, which are which is taken from our venous blood, as well as bone marrow, which can be a multipotent cells. And in that adult stem cell, there are different types like hematopoietic stem cells, skin stem cells, neural and mesenchymal stem cells. Our area is about the mesenchymal stem cells, which can develop into any mesodermal tissue, which can replace the cartilage, muscle, bone, tendon, and ligaments. So, stem cells in healing the bone. So, these stem cells can be injected into the fracture site, which can form a scaffold, which can mineralize in the subsequent weeks and help in the bone union. You can see the picture. The left side extreme is that there is a gap in the fracture site. After injection, up to we waited up to 8 to 12 weeks. You can see the radiological union. By end of 1.5 years, it had a complete union. This patient was a non-union case, which was about to undergo a surgery. So we avoided a surgery by doing a mesenchymal stem cell therapy. And this is an important topic, avascular necrosis, which we commonly see these days. Nothing but osteonecrosis. The bone becomes ischemic due to compromised microvascular circulation within the bone, and finally it ends up as a necrosis. And the bone needs blood supply, that is vascular neogenesis, to recover from the osteonecrosis. Otherwise, it will go for a collapse. When the bone is involving the joint, it will become a secondary arthritis in the future. This is the basics about the blood supply of the femoral head, where head receives 80% of the blood supply from retrograde supply. And the commonest site of AVN is the hip joint, as well the shoulder, knee, and other joints can have, talus can have osteonecrosis. Post-COVID scenario, we are seeing a lot of cases which is in the increase, and even diaphyseal bone of the diaphyseal part of the bone gets necrosed in the future. So, what are the causes of AVN? This can be secondary to a trauma. Hip joint undergoing a dislocation or a fracture of the neck can eventually end up in a AVN. And steroid abuse. Commonly, the respiratory symptoms, URI, and other skin disorders, we use steroids commonly. Our people will take the medicines without doctor's advice. They abuse the drugs for years together, and finally they end up in developing a AVN. And excessive alcohol usage and smoking also causes the AVN of the hip joint. Apart from this, the idiopathic cause is one of the major cause of AVN. There is no reason for the necrosis in the bone. What are the symptoms of AVN? Initially, the patient may not have any symptom. Once the disease progresses, they may have a mild pain in the hip joint. Many will present with pain in the knee joint. So any knee pain, you need to examine the hip first. So without completing the hip examination, knee examination is not complete. And the pain might increase when the disease progresses. Initially, the pain will be more in the weight bearing time, Later, it becomes a constant pain. Finally, they cannot even move the joint, and it'll hamper their day-to-day activities. So, how do you diagnose it? By doing an X-ray and MRI. And what are the treatment options? If you have diagnosed early with the mere rest and medications, analgesics, and physio rehab, you can treat this pain. If the pain progresses, then you need intervention. Intervention can be, a surgery. So, what are the surgical options in AVNS? Bone graft, where we drill the necrosed bone and replace it with the cortical or cancellous graft. Apart from that, we can do osteotomy, where the collapsed bone, we can rotate it, and the healthy bone can be made to participate in the joint. And there is a technique called core decompression, where you decompress the core of the bone and create a channel where the new vessels, blood vessels will form, and it will heal the necrosed portion. And also there is an entity called vascularized bone graft, where we take the bone like fibula with the blood supply and get anastomosed to the nearest major vessel around the hip joint and give a vascularization in the necrosed portion. And finally, when nothing works, the total joint replacement will play a major role. That is the last option for any avian pathology. So, how this stem cell is changed the fortune of the avian patients is, the mesenchymal stem cells have been applied to regrow the dead bone tissue, and this can be done meticulously to give a better result. So, what is the method is, you aspirate the bone marrow from the iliac crest, approximately 50 to 60 ml of bone marrow we aspirate, and which will be centrifuged, and we take the bone marrow aspirate concentrate, which will be 5 to 6 ml. If it is a bilateral pathology, we divide into two portions. So 3 to 4 ml each side we inject into the core decompressed area with under image guidance. So this is a case scenario where this is one among the cases which we have done in the recent past. This patient is a 35-year-old male who presented us with a hip pain, bilateral, difficulty in walking. And in fact, he came last year. We examined him and we diagnosed him with X-ray and MRI to found to have a avian stage 1 last year itself. So, but the problem is our people will never believe allopathy. The belief in allopathy is going down. So he went to pillar and post, all Ayurvedic treatment, acupuncture, pressure, whatever, alternative therapy, whatever people say, they go there. And finally, he comes to us again with a stage 2A in the right hip and stage 3 in the left hip. So this time we explained to him, see, once they reach stage 3, replacement will be the only choice. But since the patient is 35 years and he didn't want to have a replacement for his hip joints, we give him the choice of core decompression with the stem cell therapy, which is the bone marrow therapy. So we took him for surgery. We did a bilateral core decompression with image guidance. We hit exactly the necrosed bone. We drill it. We make a cortical window. We branch out and drill the avascular zone. Then we harvest bone marrow from the iliac crest. We centrifuge it, take the aspirate concentrate, and inject into the drilled area and seal it with the bone plug. So he'll be rested for 6 weeks. Then the regeneration has been expected, and once the pain subsides, we'll mobilize him with a good physio rehabilitation. So if you see that, this is the bone marrow aspiration which we did in our theatre. We use a vac lock syringe which has a graded vacuum method to aspirate the bone marrow, which will take some time. See, this is the vac lock syringe, so which we do under sterile aseptic method. Sorry. So these are the chambers where we take the bone marrow aspirate, and they use it for centrifuging and get the aspirate concentrate. So this is the method where we inject and we get the centrifuged bone marrow aspirate concentrate. And this is the image guided drilling of the bone. You can see that the subchondral bone in the femoral head is necrosed, where we have hit the right spot and we drill it. This is a lateral view, and we inject the stem cell into that zone and we seal it. And this will help in neovascularization. It will supply the platelet-derived growth factors, bone morphogenic proteins. Everything will help the osteoblastic activity of that region, and it will heal the necrosed bone. So stem cells can be used in cartilage repair and arthritis, where we harvest the venous blood and prepare it as a PRP and inject into the damaged joint. This can be done as an outpatient procedure. So, and in our study, we have found instead of giving a mere steroid injection into the joint, giving PRP with hyaluronic acid, which is a viscosupplementation of the joint, has given a good result, and patients are happy than the steroid injections. And stem cell injection in tendon repair, which is more commonly we do here. So we harvest the venous sample, we prepare the PRP, and we inject the pathological tendon with ultrasound guidance. Merely giving an injection blindly won't help. You hit the right spot with the ultrasound guidance. So these are the methods where we draw the venous blood and prepare centrifuge and inject into the specific area. And this is one of our patients who is a 24-year-old male. He is a national cricketer. He is part of Chennai Super Kings team member who had a wrist pain. He is a captain of Dindigul Dragons TNPL team as well. He had a consistent wrist pain, and in fact he couldn't play well in this tournament because of the wrist pain. So we examined him and diagnosed him to have a extensor carpi ulnaris tendinitis with a longitudinal tear. So we explained him about the procedure. We took him to the ultrasound guided PRP injection followed by physio rehab. After 12 weeks, he is happy, and now he is participating in the coming IPL auction, and he is ready for the IPL game. This is the image of the extensor carpi ulnaris tendon with the longitudinal tear. This is another patient who is a pediatrician from Pollachi. He is a 60-year-old male who had a pain in the shoulder joint with restricted movements. So we diagnosed him clinically to have a adhesive capsulitis with supraspinatus tendinosis. So we gave him medications, physio rehab, conservative treatment, wax therapy, everything we gave him. 3 weeks, he was partly improving. And then again, the pain recurred, and he's not happy about doing physio alone. So we explained him about the choice of manipulation under GA with ultrasound guided injections. So we took him to procedure. So this is the manipulation method under general anesthesia. We manipulate the shoulder before injecting. We achieve full range of movements. So this is another image. And this is the ultrasound guided injection of the PRP over the shoulder. That is a supraspinatus tendon, acromioclavicular joint, and even he had an early slap tear. So we hit the spot rightly and injected 2 ml into the supraspinatus, 1 ml for the acromioclavicular joint, and 1 ml for the slap tear, which is the glenoid labrum. So this is the left side. You see the tear, the rounded portion. After 12 weeks to 16 weeks, you can see the healed part of the supraspinatus tendon. So stem cells in ligament repair. See, generally degenerative mucoid degeneration of the ACL, we can give a guided injection of PRP into the ligament. As well, we can do the same for the meniscus. You can see the healing within 4 to 5 months of the time. Also, we can try the stem cell injection for lumbar disc degenerative pathologies and facet joint pathologies. with a good result. These are the minimally invasive techniques to heal the pathology. Instead of taking up for surgery every time, this can be tried before contemplating any patient for surgery, and we have given good results. And also we can create a 3D scaffold using hyaluronic acid and collagen, which can be used in disc pathology, where you can fill that scaffold with a PRP injection. And in conclusion, with our experience over the last 5 years in SRH, we have done a lot of PRP therapy and BMAT therapy, which has given encouraging results so far, which is a good milestone in regenerative medicine. I hope many know this guy. He is the one who's been a part of CSK team, and probably this time he might enter Rajasthan Royals. He is the one who came for an extensor carpi ulnaris tendon therapy. Hari Nishant, one of our team player in our club. Thank you.
Thank you, Dr. Gokul. Any questions are welcome from the audience. Any interaction, discussion?
Excuse me.
If there are no questions, then I thank Dr. Mohan, Dr. Vijayaraj, and Dr. Gokulakrishnan for sparing their time and coming here and delivering very useful discussion here. And I think most of the audiences would have been benefited by these lectures. And our next meeting also will be from the Department of Rheumatology and Plastic Surgery. And rheumatology topic about rheumatoid arthritis, update on rheumatoid arthritis, and from the plastic surgery department, treatment options in gynecomastia. So that will be on 23rd of December, Friday. And I thank all the audiences, today's consultants, doctors from inside the hospital and outside Ramakrishna Hospital from the Coimbatore town. I thank all of them. And once again, I thank all the speakers of today on behalf of management. Thank you.